We've all had a nosebleed, right? That sudden, sometimes messy little inconvenience.
Mm-hmm. Pretty common.
But what happens when a nosebleed isn't just, an annoyance, but actually a life-threatening emergency? We're going to dive deep into something called intractable epistaxis.
Right. The really serious ones.
Yeah. So today, our mission is to unpack endovascular embolization. It's this cutting-edge procedure that has really, truly revolutionized how doctors treat these severe bleeds.
It's a huge leap forward.
We want to explore why it's such a game changer and maybe uncover some of the precise, kind of surprising details that make it work so well. We've got an expert radiology report as our guide here, packed with insights.
Yeah, it's quite detailed.
And we're going to pull out the most important bits for you.
Okay.
So, let's start with the problem itself. Most nosebleeds, like we said, minor. They start at the front of your nose, stop on their own, usually.
Right, the anterior ones.
Yeah.
Usually manageable.
But there's this small but significant percentage that are severe. They originate way back, deep in the nasal cavity.
These are the posterior bleeds.
Exactly. And they are notoriously difficult to control. They can lead to some pretty serious complications, things like obstructing your airway or accidentally breathing in blood.
Aspiration, yeah. Very dangerous.
And just significant, dangerous blood loss.
And what's really, I think, urgent about these cases is just how quickly they can escalate. We're talking about situations where the usual methods, maybe nasal packing or cauterization, they've already been tried and failed.
Right.
That's what makes them refractory or intractable. They won't stop bleeding with the standard approach.
Okay, so that really sets the stage, and this is where the solution we mentioned comes in, endovascular embolization. So describe this a bit. It's minimally invasive, right? Guided by X-ray.
That's right. It's minimally invasive. Doctors use real-time X-ray imaging, fluoroscopy, to carefully guide a tiny catheter, usually starting from an artery in the groin, the femoral artery.
All the way up.
All the way up, navigating through the arteries to precisely block the specific blood vessels inside the nasal area that are causing the bleed.
Wow. Okay.
And this technique, it really represents a fundamental shift. Traditional packing, it can be quite uncomfortable for patients.
I can only imagine.
Yeah, and its success rate, well, it varies, but often under 85%. Embolization, on the other hand, is consistently described in reports like this as well-recognized, preferred, efficient, and safe.
So better outcomes and less invasive.
Generally, yes. Less invasive from the patient's perspective compared to, say, open surgery. And crucially, it significantly cuts down that risk of accidentally breathing in blood during the bleed or the procedure.
That makes sense. So knowing how effective this is, who typically gets this procedure? Is it for everyone with a bad nosebleed?
Not necessarily the first step. Often these cases are actually idiopathic, meaning we don't find a specific cause.
Huh.
We see it more often in older patients, maybe people with high blood pressure, or quite commonly individuals who are on blood thinners.
Ah, that makes sense.
But there can be other causes too. Things like facial trauma, sometimes rare tumors like something called juvenile nasopharyngeal angiofibroma, JNA,
Okay.
or even unusual vascular malformations. And one key point, if you are on antiplatelet or anticoagulant meds, those blood thinners, you do have a somewhat higher chance of the bleeding recurring, even after a successful embolization.
Right, something to keep in mind.
Definitely. And this all leads to a really important question. Safety. How do we make sure this incredibly precise intervention is safe?
Yeah, you're threading catheters through arteries.
Exactly. The absolute most critical thing, anatomically, is avoiding what we call dangerous anastomoses.
Okay, what are those?
Think of them as tiny, unexpected connections or shortcuts between blood vessels. Specifically, connections between the external carotid artery system, which is where we're usually targeting the embolization, and really critical areas supplied by the internal carotid artery, like the brain or the ophthalmic artery going to the eye.
Oh, wow. So you wouldn't want the blocking agent going there.
Absolutely not. If the embolic material, the stuff used to block the vessel, accidentally travels down one of these pathways, the consequences can be devastating. We're talking stroke, blindness, serious complications.
So how do you avoid that?
Meticulous planning. That's why detailed pre-procedural imaging is non-negotiable. Specifically, mandatory angiography, which is like an X-ray map of the blood vessels of both the external and internal carotid artery systems. It's not just for finding the bleed, it's absolutely crucial for mapping out these no-go zones.
So it's like creating a personalized safety map before you even start.
Precisely. It allows for a highly individualized safety-first approach.
Okay, that focus on safety, especially those pathways, is clearly paramount. So once you've mapped everything out, how does the procedure actually happen? Access is usually the groin, you said.
Typically, yes, through the femoral artery.
Mm-hmm.
Then, using those microcatheters, really tiny tubes, the interventional radiologist navigates right up to the target bleeding vessels.
And then they block it? With what?
They inject a special blocking agent, an embolic agent. Often it's tiny particles, like polyvinyl alcohol or PVA. They're like microscopic beads designed to lodge in and plug the vessel.
Okay.
But if those risky connections, those anastomoses, are a big concern.
Right. The dangerous ones?
Yeah, then they might use a different agent, maybe a medical-grade glue,
Hmm?
N-butyl cyanuricrylate, or NBCA. It hardens very quickly on contact with blood, which can make it less likely to drift downstream into those unwanted areas.
Interesting. What about things like coils, like little metal spirals?
Generally, coils are avoided for epistaxis embolization, and there's a key reason: permanence. If the bleeding were to unfortunately recur later in that same vessel distribution.
You couldn't treat it again the same way.
Exactly. The coil physically blocks the path, preventing future embolization attempts in that specific vessel. So particles or glue allow for potential retreatment if needed down the line.
Got it. That makes sense. What about success rates? You said it's effective.
Incredibly effective immediately. The reported technical success rates, meaning stopping the bleed right then and there, are very high, generally ranging from 89% up to 100%.
That's impressive. What about complications, though? We talked about the big risks.
Overall, complication rates are generally low, around 17% reported in some studies. The major ones we discussed, stroke, blindness, tissue damage, are rare, thankfully. We're talking 0 to 4%. And those are almost always linked back to those dangerous anastomoses, or sometimes using particles that are maybe too small and travel too far.
Okay, rare but serious. What about minor issues?
Minor complications are more common. Things like temporary headache or some facial pain or numbness near the treated area. Those can occur in maybe 18% to up to nearly 60% of cases, but they typically resolve on their own.
Right, manageable stuff usually. And after the procedure, what does recovery look like?
Post-procedure care is important. You'll need to keep the puncture site in the groin clean and dry. Avoid any strenuous activity for a few days. And then, specific to the nosebleed issue,
Don't pick your nose.
definitely don't pick your nose or blow it forcefully. Using a humidifier can help keep things moist. And if you absolutely have to sneeze, try to do it gently with your mouth open to reduce pressure.
Good tips.
And this is especially critical for patients with certain underlying conditions, like HHT, hereditary hemorrhagic telangiectasia, where blood vessels are inherently more fragile. Good nasal care is key.
So, wrapping this up, it seems endovascular embolization really is a highly effective, generally safe treatment for these tough, intractable nosebleeds.
It certainly is.
But what really struck me looking through this report is how its success isn't just about the fancy tech, the catheters, and imaging. It seems to fundamentally hinge on the radiologist's deep, deep understanding of that complex vascular anatomy.
Absolutely critical.
And meticulous technique combined with really looking at the whole patient picture.
Exactly. It's a blend of technology and expert anatomical knowledge and careful clinical judgment.
Yeah.
But what's really quite striking and maybe a bit concerning in the source material is the comment that despite how effective this is, despite the established best practices, referral pathways for embolization are, and I quote, not frequently done.
Really? Even though it works so well.
Apparently so. And that really raises a critical question for us to think about. What might be the actual real-world impact of delays in getting patients referred for this procedure? Especially when we know that severe posterior epistaxis can escalate so quickly and be genuinely life-threatening.
Yeah, what are the bottlenecks?
What might be the obstacles?
Is it awareness?
Logistics, communication between, say, emergency departments, ENT specialists, and interventional radiology. It makes you wonder about the coordination needed between different medical specialties to ensure patients get this potentially life-saving treatment faster.